Dr. Ibrahim is a consultant anesthesia and تخصصي branch. He is a board certified anesthesiologist, and he is a big interest in regional anesthesia and acute pain management. He will talk about total knee arthroplasty and
Assalamu alaikum. First, I want to thank Dr. Nasser and the organizing committee for inviting me to this wonderful meeting of the third HMG Anesthesia Conference. My name is Dr. Ibrahim, and my region of interest is regional anesthesia. And today I'm bringing a fatty topic. It's a very heavy topic. I will try as much as possible to finish this topic within 5 minutes. I'm going to go fast through the areas which maybe is not your interest, and in the area of maybe becoming interesting, I will stop over this areas. There is nothing to declare. I want just to tell you that on my slides you will find on the lower left of the slides there will be the QRs, which is a link to references of my slide. So if you want to check the reference to know the source of my slide, just use these QRs. If you look to this graph, it will show you the progression of number of total knee replacements in USA starting 1993 till 2012. And we see how much is business of the total knee replacements is heavily increasing. And if you look to this study also, which shows that expected on 2050 compared to 2012, there will be an expected increase about 143% of the total knee replacement cases done in the United States. We shall, at the beginning, understand what our surgeons want. It's very difficult, okay, to understand our surgeons like what women want. So what our surgeons want? They want early mobility. What else? Early mobility. What else? Early mobility. They need early mobility. So what our surgeons need? Early mobility of their patients. If you reach this goal, early mobility, I think you will satisfy your patient, your surgeon, and you will be like a magician, you're making his dreams come true. If you look to this patient is about 65-year-old. She's doing bilateral total knee replacement, and she's in the PSU. And what we give her full mobility, full total sparing. You can see this is in the recovery unit. And what I'm going to do, how we do it, how we reach the point that the patient can move, can walk, can move his legs without affecting his motor power. In regional blocks for total knee replacements, there is like an evolution. I call it evolution of blocks of lumbar and sacral plexus in analgesia for total knee replacement. In the Stone Age, we used to give epidural analgesia post-operatively and intrathecal morphine. We want to block the plexus from the beginning with our epidurals or with our spinal. But we developed more. We think that why we block higher, why we paralyze both legs, why our operation in one leg. So we moved in the modern, where some of us use the classic approach, giving femoral block or sciatic block to one side to control the pain. But recently in the space age, we are going to give the terminal sensory branches innervating the knee without affecting the motor power of the knee. Let's review together what is the nerve supply of our knees. On the left side, the anterior nerve supply, starting with the famous saphenous nerve, which is responsible for anterior innervation of our knees. And also, we will go to the nerve to vastus medialis, which is a very important nerve, which is innervating the anterior medial capsule part of the knee. And this nerve is very important to consider during our blocks. Also, there is the group of the geniculars, starting with the supromedial genicular nerve and supralateral genicular nerve, inframedial genicular nerve, and infralateral genicular nerve. Also, we should consider another genital nerve, which is nerve to vastus medialis. We target all these nerves except the infralateral genital nerve, because the infralateral genital nerve is known that it's very close to a nerve which we don't like to block, which is the common peroneal nerve. If some of your local ends up near to the common peroneal and blocks the common peroneal, you will end up with foot drop. So we avoid this nerve during our blocks. Posteriorly, the knee is mainly covered by the obturator nerve, the posterior branch, the articular branch of the obturator nerve, and the sciatic nerve. Usually we target these nerves, but the sciatic we don't approach because we don't want our patient to come out with a foot drop. So, what's our target? Our target are 10 targets, 10 nerves we need to block. If we block these 10 nerves, so we are blocking the sensation of the knee without affecting the motor power of the knee. The first, as we said, is the saphenous, nerve to vastus medialis, supromedial genicular nerve, superlateral genicular nerve, inframedial genicular nerve, nerve to vastus intermedius, infragenicular nerve, inframedial genicular nerve, and obturator nerve, the articular branch, and also the posterior capsule sciatic sensory branch, and don't forget the anterior femoral cutaneous nerve. How we reach to block these nerves? Is it difficult? No, it's very, very, very easy approach, and I'm going to show you now how to block these 10 nerves. First, let's review the anatomy of the thigh. We have the famous block, which is the adductor canal block. Now, most of the anesthesiologists, they give a single shot in the adductor canal to control the pain of the patients. But are we really giving our block in the adductor canal? If you look to the anatomy, there is this area is called a femoral triangle, okay? And down there, this green box, this is the adductor canal. They found that most of anesthesiologists, they deposit the local anesthesia inside the femoral triangle, not the adductor canal. That's why there is a new approach now, which is called the true adductor canal. Are you giving your injection in the true adductor canal, or you're giving your injection in the femoral triangle? Does it make difference to give it up here in the femoral triangle or lower in the adductor canal? Yes, it makes difference, because in the femoral triangle, the motor branch going to quadriceps coming from this area. And if you block the motor branch going to the quadriceps, it will end up by quadriceps weakness. Additionally, there is some quadriceps weakness caused by the surgery itself, so you'll have a great weakness and the patient cannot move immediately post-operatively. So it's very important to avoid the adductor canal. So are we going to inject lower in the adductor canal? Does it make difference to give it high in the adductor canal or low in the adductor canal? They did this study, actually, this is a Gravel study, which they injected a dye on many levels, multiple levels. High, they injected low in the adductor canal and in the midpoint between the femoral triangle and the adductor canal, and they injected also in the femoral triangle high. They found when they injected in the femoral triangle, they are affecting the nerve to motor nerve to quadriceps. But when they go down, more down to, if you can see my mouse here, I cannot see my mouse. If they can go down here, they are sparing the nerve to vastus medialis, because nerve to vastus medialis in the adductor canal goes migrate laterally away from the adductor canal. So there is a big chance that you may lose the nerve to vastus medialis if you go low in the adductor canal. So where is the best area to inject? The best area actually to inject is at the junction between the femoral triangle and the adductor canal. By this way, you are sure that you are targeting the nerve to vastus medialis, and at the same time, you are sparing motor effect of blocking nerve to quadriceps. If you look here to this imaging of the well-known adductor canal, up here you can see the sartorius, and down the adductor longus. Here there is the scan on 3 levels: high in the femoral triangle, medium, which is intermediate between the adductor canal and the femoral triangle, and low in the adductor canal. If we look here, how we can identify by scanning where to block. If you look to the image here, you find that when the sartorius is small and the adductor longus is big, as you can see, the sartorius up there, and the adductor longus is down there. You see the sartorius is smaller than the adductor longus. That time you are still on the femoral triangle. But if we look to the second image, the sartorius is almost the same size of the adductor canal. This means that you are in the junction between the femoral triangle and the adductor canal. But if we look to the third image, the adductor longus is the one here, which is not marked. The one down here, and the sartorius is overlying the adductor longus. That time you are low, very low on the adductor canal. So we call this image like a prayer sign. You know the prayers, usually they do this sign. It looks like the prayer sign. If you look from the other side, the image of the muscles, the sartorius and the adductor longus, it mimics the image of the prayer sign. We call this sign the prayer sign. Once you see this prayer sign in your ultrasound, this means that you are at the junction between the femoral triangle and the adductor canal. And the best point to inject your local is on this area, between the adductor canal and the femoral triangle. If you see, look here to this image also, we go with our needle between subsartorial, between the sartorius and the adductor longus, and we subsartorially we inject. What I do actually, I do like a hydrodissection going under the sartorius till I reach the adductor canal, and this is the prayer sign which I told you. If we look here, this image is mimicking the image of the prayer sign. So what is the problem? The problem that we know very well that the saphenous nerve is very close to the artery. But as I told you before, the nerve to vastus medialis sometimes it migrates laterally. So we are sure, yes, this is the saphenous. But where is the nerve to vastus medialis? Is this one, or that one, or that one? Sometimes we are not getting sure which one is the nerve to vastus medialis. It could be any one of these nerves. So what we do actually, and there's another problem. The other problem that they found that in between the nerve to vastus medialis and the saphenous, there is some fascia which is called the vasoadductor membrane. The vasoadductor membrane make it like two separate planes between the nerve to vastus medialis and the saphenous nerve, which make it, if you inject directly the nerve to vastus medialis, you may miss the saphenous nerve, and if you inject direct to saphenous nerve, you may miss the nerve to vastus medialis, because there is a fascia layer between them. So how we solve this issue? How we solve the issue that we are sure that we block the nerve to vastus medialis and we blocked the saphenous nerve? We use our old friend, nerve stimulator. We go with our nerve stimulator, and once we get, of course, the saphenous nerve will not be stimulated because it's a sensory nerve, but the nerve to vastus medialis is a motor nerve. We will get a contraction in the vastus medialis muscle, so we are sure now that we hit the nerve to vastus medialis. Then we proceed to hit the nerve to vastus medialis. As you can see here in this video, I'm coming with my needle from lateral to medial below the sartorius, and once I suspected this area is the nerve to vastus medialis, I inject my local anesthesia. Actually, I'm injecting half of my local, I'm giving 20 ml. This is half of my local anesthesia. Then I proceed, after giving the block, I proceed and pierce the fascia, as you can see. And after piercing the fascia, now I'm giving my local to the saphenous nerve. So I'm giving half of my local to the nerve to vastus medialis and the other half to the saphenous nerve. Now we achieved 2 targets from our 10 targets, if we remember before. Now we block the saphenous nerve and the nerve to vastus medialis with 1 injection only. Okay? Now let's move to the next target, and the next target you can achieve it from the same entry point also. In the same entry, don't take out your needle. From the same entry point, you can block a very easy nerve which is called the anterior femoral cutaneous nerve. The anterior femoral cutaneous nerve, the down here, number 10, it's not important because it's supplying the skin only. It's important because they found the anterior femoral cutaneous nerve is supplying the fascia lata, which is very important in controlling the pain. If you didn't block this nerve, you will have the pain coming from the fascia lata of the pain. So it's very important to block the anterior femoral cutaneous nerve. How to block the anterior femoral cutaneous nerve? Just look here. This is the sartorius. Look on the upper border of the sartorius, okay, on the subcutaneous area, you can search for small nerves. Just deposit some local above the, usually I deposit some 5 or 6 mL of local over the border of sartorius. That time you are pretty sure that you hit the anterior cutaneous nerve of the side. Now we reach 3 of our targets. Let's go for the biggest target now, which are the geniculars. Geniculars are very, very easy blocks. You just put your ultrasound on the side of the knee, you just scan and find where is the bone. You inject your local above the condyles, the medial and lateral condyles. It's very easy block. There is no need to search for the genicular artery. If you deposit your local anywhere inside this area to reach the artery, okay, the only importance to scan for the artery is just to avoid injection to the artery. Okay, so in the researches they said there's no need to scan where is the artery exactly, because the area is very close area, and if you inject 5 to 10 ml of your local inside this area, it will spread all over, and you are sure that the genicular nerve will be hit with your locals. As we said before, the infralateral, we don't come close to the infralateral because it's very close to the common prenatal, and by the end we may have a foot drop. As I said before, on my way, I come usually out of plane. I go above the medial and lateral condyle. I deposit my local anesthesia, and sometimes I'm sure that the geniculars are well blocked. This is an ultrasound image which you usually see. Sometimes we see the genicular artery, and beneath to the genicular artery is the genicular nerve. But if we even put our needle here and we deposit our local, you find your local will spread to the genicular nerve. And this image comes from the tibia, the infromedial, and in the infromedial, actually this is the tibial condyle here, and this is the tibial shaft. You will find some depression here. And inside this depression, you will find a pulsating artery. This is genicular artery. Just put your local in this depression. And you will hit the inferior infromedial geniculars. This study shows how important is genicular nerve in controlling the pain, and if you see here, the using of genicular nerve, it increases the ambulation distance of the patient, and it decreases the consumption of opioids. Now we reach the target by giving 8 nerves out of 10 nerves, which we targeted before. The remaining nerves are the obturator and the posterior sciatic. Posterior capsule sciatic sensory branches. How we block these nerves? We block the nerves either by using the IBAC, and there is a lot of studies telling how IBAC was helpful in posterior in controlling posterior pain. And you just deposit your local here between the posterior capsule of the knee and the popliteal artery. You put your needle, medial to lateral or lateral to medial, as you like, and you just spread your local here in this area. If you look to this video, here, actually this is the lateral condyle here, and this is the medial condyle, this is the popliteal present. I come with my needle, or come up with my needle from lateral to medial, and I'm spreading my local anesthesia here, below the artery, and above the posterior capsule of the knee. Right. If you are not aware about giving IBAC, because technically for maybe new users, the IBAC sometimes it's not as straightforward block. Sometimes it's relatively technically difficult. Okay, sometimes you can go for local infiltration. Just prepare some local anesthesia. No need to prepare a high concentration one. For me, I'm using a concentration of 0.15% of ropivacaine in 50 ml, and I'm giving to my surgeon. And sometimes, when you give a local anesthesia to your surgeon, only God knows when he injects your local. So you have to guide him. You have to tell him where to inject. I usually tell my surgeons, please put all this local on the posterior capsule, behind. Because this area is very difficult, because the nerves there are not visible, the articular branch of the obturator is not visible with the ultrasound, the sensory branch is coming from the sciatic, it's not visible before the ultrasound, and it's very difficult to find them, so you can do it by using the local infiltration. Now we reach our target, which is 10 nerves. Which local anesthesia we use? For me, I prefer ropivacaine. Why ropivacaine? Ropivacaine According to all studies, its duration is quite similar to bupivacaine. You can see here bupivacaine compared to bupivacaine 10.9 to 11 hours, and other studies 16 to 17 hours. There is no big difference. Also, you can use dexamethasone to prolong your ropivacaine timing. So it's if you use ropivacaine with dexamethasone, the timing you can see here with the dexamethasone is 22.2 hours compared to 22.4 hours for the bupivacaine. So there is no big difference between both of them. Also, regarding to the toxicity, the bupivacaine is known to be more toxic than ropivacaine, and ropivacaine is more safe regarding toxicity. Also, regarding the cardiac toxicity, we know all local anesthesia are cardiotoxic, and the bupivacaine is more toxic than levobupivacaine, and the most safe is ropivacaine. That's why I choose ropivacaine. If we can look here to this interesting study, they brought some dogs and they injected the dogs with ropivacaine and bupivacaine and levobupivacaine until these dogs are arrested, and they resuscitated the dogs. You know how much dogs regained from resuscitation? In case of ropivacaine, bupivacaine, 50% only of the dogs revived. But levobupivacaine can up to 70%. But so in the ropivacaine group, 90% of the drugs who received arrested from the ropivacaine, 90% of them revived. So ropivacaine is more safe. Also, the safety profile. This study actually done on local infiltration analgesia during knee arthroplasty. When they injected ropivacaine of 270 milligram dose, they found after 4 hours, after the peak serum concentration is 0.46 microgram per ml, while after 24 hours it's only 1 microgram per ml. 270 milligram actually of ropivacaine is the maximum dose of ropivacaine. You know, its serum concentration after 24 hours is only 1 microgram, while the toxic dose of ropivacaine, the serum toxic dose is 3 microgram. Even you have a long range of safety. Which is better, catheter or single shot? Most of the studies, most of the systemic reviews, they said catheter are better in controlling pain. But in one condition, you should have acute pain service. If you have acute pain service in your hospital, go on for the catheter. If you don't have, so at that time, send the patient to the ward, and after 24 hours or 48 hours, you can go for a single shot to, if there is anterior pain arise from the surgical site. Regarding insertion, how to insert the catheter. There's two protocols, the parallel protocol and perpendicular protocol. If perpendicular means that you are putting your catheter perpendicular to the nerve. That time they found the migration rate is very high. It reaches in the perpendicular approach, it reaches 74%. Your catheter will go outside of its place, and you need to reinsert the catheter, because the catheter is not with the anatomy. But if you insert, as you see here in this photo, if you insert it on the parallel way, that time you have the migration rate reduces until 14%. Recently, as I said in the last discussion, in the American Society of Regional Anesthesia in 2023, they discussed what's called modern anesthesia. They discussed what's called modern general anesthesia. We're giving general anesthesia using either Tiva or Destroyed, but we avoid using opioids. You know what is the result? The result is like this. This patient, this patient what you see on the table, immediately after the surgery, he's moving his legs very well, he doesn't have opioids, he's fully conscious, and he can move immediately after the surgery. So what's the take-home message? Motor sparing analgesia is very essential to enhance energy mobility. Also, genicular nerve block enhances pain control and reduces opioid consumption. Also, adductor canal catheter provides better pain control than single shot block. Also, ropivacaine is much safer than bupivacaine, and using dexamethasone enhances the duration. And lastly, the modern general anesthesia is associated with less complications and enhanced recovery. Thank you very much.